poisoning. It's one of those emergencies that can walk through the doors of any primary care center anytime, and it needs fast, structured action. So let's break down what I do when I'm faced with a suspected poisoning. Step 1. ABCDE assessment. Always. That means airway, breathing, circulation, detect and correct. Think hypoglycemia, seizures, temperature problems, and then emergency antidotes if they're available. Every second counts, so I move fast but stay systematic. While I'm doing that, I'm finding out what poison was taken, how much, and when. The details can decide everything about what comes next. Was it pills, liquids, chemicals? Did it happen minutes ago or hours? Get the family talking, look for bottles or packets, anything that can help. If the patient shows up within an hour of swallowing the poison, I consider gastric lavage. But here's the catch. It's only for non-corrosive poisonings. No acids, no kerosene, no petroleum products. Those can burn the gut, and lavage can make things worse. If it's safe, I grab the largest NG tube I've got, use normal saline or tap water, and make sure the patient's in the lateral position to keep their airway protected. Before I even think about that tube, though, I check for poison on the skin or eyes. Poisons aren't just swallowed. They can be absorbed through skin and mucous membranes too. So I remove all contaminated clothing and I wash the skin and eyes thoroughly for at least 20 minutes. My goal? Stop any more poison from getting in. Activated charcoal is a lifesaver, but timing is everything. If it's within an hour of ingestion, I mix up 1 gram per kilo of body weight, max 50 grams, in about 200 milliliters of water. I put it through the stomach tube or down the NG tube if I haven't done a lavage. Flush it down with a bit of plain water. And if the patient vomits it up within half an hour, I just repeat the dose. If the patient is unconscious or only semi-conscious, first thing, I check their blood sugar. If that's not possible, I don't wait. I give 50 milliliters of 50% dextrose. Kids get 5 milliliters per kilo of 10% dextrose. Hypoglycemia can be deadly, and I don't want to miss it. IV fluids are next, helping the kidneys flush out whatever they can. And once the patient is stable, referral is critical. I send them to the hospital, along with the packet or bottle if it's available. I always explain to the family, things can change suddenly, and they need to be ready. Now, a special warning with corrosives. Think kerosene, petroleum products, acids. These are especially dangerous in kids under 5 or anyone with suicidal intent. In these cases, no tubes, no charcoal, no washing out the stomach. It's a straight shot to a tertiary center. Time is everything. Acute poisoning can be chaotic, but with a clear protocol, I can make a real difference, right from the primary care center. Remember, stay calm, stay systematic, and always be ready to act.